Good morning, everyone. My name is Adiam Radai Woodson, and I am the Assistant Director of HIV and Hepatitis Prevention for the Division of Disease Prevention at Virginia Department of Health. We start the second day of our Quality Management Summit with a presentation on Virginia's Ending the Epidemic Plan, presented by Ashley Yoakum. Ashley Yoakum is currently the HIV Care Services Planner for the Virginia Department of Health Ryan White Part B program. She has over 5 years of HIV experience, having previously worked in various roles in HIV prevention and HIV care services at VDH. She currently holds a bachelor's degree in psychology from Longwood University. Please welcome Ashley Yoakum.
Hi, everyone.
Good morning, roles in HIV prevention.
Hi, everyone. My name is Ashley Yoakum, and I serve as the HIV Care Services Planner. And today I'm going to be talking about the Virginia Integrated HIV Prevention and Care Plan, also known as the Virginia Integrated Plan for short. And so the first iteration of the Virginia Integrated Services Plan was developed in 2016 and went from 2017 to 2021. This was a 5-year plan that focused on the goals and initiatives from the National HIV/AIDS Strategy. The Integrated Plan is a statewide plan on how we are addressing and responding to the HIV epidemic here in Virginia. This plan was submitted as a joint integrated plan with the Norfolk Ryan White Part A Transitional Grant Area, as well as input from both the TGA and the Community HIV Planning Group. All right, so currently VDH is working on developing the second iteration of the integrated plan, which will also serve as Virginia's Ending the Epidemic Plan. This plan is due to our federal partners on December 9th, 2022. So we have about a month left. And so what we have done is we've taken a look at what we were able to achieve with the first integrated plan, and then we've taken those achievements as well as opportunities into and put those into what's going into the next plan, just to make sure that we're able to continue to make progress on addressing and ending the HIV epidemic here in Virginia. The guidance asks us to arrange our goals according to the HIV National Strategic Plan, as well as make them inclusive of the EHE strategies: diagnose, treat, prevent, and respond. The National HIV/AIDS Strategy builds upon the 2021 HIV National Strategic Plan, as well as the 2 prior National HIV/AIDS strategies. And both the HIV National Strategic Plan and the Ending the Epidemic Initiative are closely aligned and complementary. So here's just a snapshot of the National HIV/AIDS Strategy that was updated in 2022. You will see here on the left side that the goals are similar to the previous National HIV/AIDS strategies, although the wording is slightly different. They've also included an updated strategy vision, as well as updated the priority populations that they want to focus on. And again, much of our plan will be based on the National HIV/AIDS strategy. And then here's just a graphic as a reminder for the 4 pillars of the Ending the Epidemic, which again, our plan must be inclusive of. Okay, and so now we're going to go into more details on the 2022 and 2026 Virginia Integrated Plan. So here is an overview of the required plan components. These are familiar as they are very similar to what was included in the previous plan. So first is an executive summary, which is just an overall summary of the integrated plan and the components. The community engagement and description of the jurisdictional planning process. This section really describes how VDH engaged with our community, as well as our process on how we developed this plan. We at VDH cannot create this plan on our own. We want to make sure and need to make sure that we are engaging with the community on what goes into this plan, as this will be a roadmap for how we address and end the HIV epidemic. In the next section, for contributing data sets and assessments, this is a summary of information that we are collecting. So first, the epidemiological snapshot, which is a collection of data on what the HIV epidemic looks like here in Virginia, including data on new HIV diagnoses, overall number of people with HIV, and it also looks at unmet need, which looks at people with HIV who have either been late diagnosed, meaning they've been diagnosed with AIDS either at the time of their HIV diagnosis or less than 3 months after, people with HIV who are not virally suppressed, as well as people with HIV who have been diagnosed but have not yet had a viral load or CD4 test. Okay. The second section is the HIV prevention care and treatment resource inventory. This is a collection of both funding available for services, as well as services available for both people who experience risk for HIV, as well as those with HIV throughout Virginia. And then lastly, the needs assessment section that looks at where there are needs and possible service gaps related to HIV prevention and care services. Section 4, which is the situational analysis. This section takes information from Section 3 and really summarizes our strengths and opportunities, as well as any gaps and service needs in the Commonwealth. It also identifies our priority populations that we want to focus on for this next plan. Section 5 are the goals and objectives. And the goals and objectives are the part of the plan that is most often referenced. And these will be the objectives and strategies of actions that we will try and do to meet the goals, the overarching goals of the plan. And lastly, the monitoring and evaluation section. This is really just a section that tells us how we are going to oversee the implementation of the integrated plan to make sure that we are meeting the goals and what we set out to do with this plan. Okay, so now I'm going to move into some very high overview of different components of the plan. I want to stress that this is just a snapshot of each of the sections and is not at all inclusive of all of the information that will be in the integrated plan. All right, so first I want to provide just a couple of highlights from our EPI snapshot. So the Eastern region has the highest number of people, both people with HIV, as well as the highest number of new HIV diagnoses. The greatest impact of HIV can be seen in the northern, central, and eastern regions. And Black, non-Hispanic males who report having sex with men are our most impacted population. Also, people in our northwest and southwest regions are more likely to get a late HIV diagnosis, indicating that they have likely had HIV for a long time. Right. Some more highlights are that linkage to care rates were lowest among our newly diagnosed persons aged 65 and older. That evidence of care was also considerably lower than our statewide rate within this age range. And then lastly, retention and care and viral load suppression were also slightly lower among people with HIV age 65 and older as compared to our Virginia overall rates. Okay, and now going through some information from our community input and needs assessment sections. A lot of the information gained from here is through multiple meetings with our community HIV planning group, as well as recent needs assessment conducted with both providers and consumers, as well as the public hearing that we held back in April to gather more input into the integrated plan. And so some of the information that came out of those activities are that more education on both HIV stigma and HIV transmission is needed. There is a need to routinize HIV testing to make it a regular part of healthcare. A need to find ways to reach out to the youth. Also that cost to PrEP has been a barrier to care, and that more education is needed on PrEP in general. including information for providers on insurance coverage options for PrEP, as well as pharmacist education on PrEP. Okay, some additional highlights are that distance to travel to access services is a major barrier. Staff turnover for case management. Additional access needed for our mental health and substance use disorder treatment services. There needs to be more innovative service delivery models and a need to address services for the aging population, including both testing services as well as care services. We need to make sure that we're considering our rural areas when planning for services, as not all areas of the state are the same. And then there's significant housing challenges, both in finding affordable housing as well as sustaining housing. Okay, so now here's just a quick summary of our resource inventory, which again just provides some information on the resources available throughout the state for both HIV prevention and care services. So just a quick overview of some of the funding information is that there is a lot more funding available for HIV care services than for HIV prevention services. And this is even less funding is available for PrEP, hepatitis, comprehensive harm reduction, and surveillance activities. There is additional funding and services available outside of what's funded through VDH, but more collaboration is needed between those funding sources to make sure we're addressing, making sure that people have access to care. And then lastly, more information is still needed about our community funding from foundations, direct funding that agencies receive from federal partners, as well as other state agencies that also provide HIV prevention and care services. All right, and so now moving into just a quick summary of services. Services are available for both people with HIV and for people who experience risk for HIV. Some prevention services include HIV and hepatitis testing, STI testing and treatment, PrEP, condom distribution, comprehensive harm reduction, which services include the distribution of sterile needles and syringes, as well as the disposal of used needles and syringes, referrals to drug treatment and other services. Our Charlie program, which provides prevention and care services for persons experiencing incarceration, as well as for people with HIV who have recently experienced incarceration. There are also services available through the HRSA Healthcare Health Center program, which provides funding for primary care services in underserved areas. In 2021, HRSA funded 26 federally qualified health centers in Virginia to provide primary care services. There are also additional housing services funded through HAPA, which can vary by region and provider. There are also more support services are needed for people who experience risk for HIV to help them remain negative. So while there are a number of services and funding available for people with HIV, there are not as many services available for those who experience risk for HIV that could help them remain negative. And lastly, there are services that are available for people who use or inject drugs. In addition to some of the VDH programs, such as our Part B, our comprehensive harm reduction, and our Charlie program, additional services are also available through our community services boards that provide services for persons who use drugs and or alcohol. Okay, and so now moving into our priority populations. These are a number of the populations that we would like to focus on in our next integrated plan. And these populations are inclusive of both people who experience risk for HIV as well as those with HIV. And specifically for people who are 50 and older, we want to make that we're focusing both our HIV testing and diagnosing efforts, as well as making sure that we're addressing HIV care services needs for those with HIV. Okay, and so now kind of moving more into our situational analysis, I'm going to go through some of the strengths that we have in Virginia, and then we'll go through some challenges and then how we're going to address those challenges through the integrated plan. So one, there are multiple avenues to getting an HIV test, including both community and clinical providers, as well as our at-home HIV testing program. We also have comprehensive harm reduction has been expanded to each of our five health regions. There are long-acting injectable options for both PrEP and ART medications. We've had expanded collaboration between our prevention and care. Virginia became a Medicaid expansion site in 2019, which has expanded access to services, including HIV testing, HIV care services, as well as other behavioral services. We have revised legislation for our syringe services, as well as our HIV decriminalization laws. We have robust consumer involvement in both our HIV prevention and our care programs. And lastly, we've had reduced new HIV diagnoses, steadily reducing in the past 5 years. Some additional strengths are the creation and expansion of our Rapid Start program, which has led to reduced time for linkage to care, as well as reduced time between diagnosis and viral load suppression. Also, with the implementation of our Provide data system, which houses all of our Part B data, including our ADAP data from our Virginia MAP program, as well as a number of prevention programs, including our Status Neutral program, our Charlie program, the Data to Care program, and PrEP. Also, the incorporation of our trauma-informed principles, as well as our unified eligibility for Ryan White Part B services that unifies eligibility for all Ryan White Part B services, again, including our Virginia medication access services provided through our Virginia MAP team, as well as other Part B services that agencies that our clients receive through agencies. And then lastly, the steady expansion of our Ryan White Part B services, as well as providers. All right, and now some challenges. So one challenge is funding that's available for PrEP and CHR services. Our network of PrEP and ID or infectious disease providers. Transportation and housing still provide a significant barrier to accessing services. And then general HIV stigma is still a barrier to accessing HIV testing, as well as other services that are needed. Okay, some other challenges are the need to focus on the aging population, especially as our population of people with HIV continues to age. We need to make sure we are focusing on additional needs from that population. Again, as mentioned earlier, more education is needed on PrEP. Additional funding and availability of support services for people who experience risk for HIV. And then lastly, provider staff retention. So we know that in addition to staff turnover for case management, there's also been a number of staff turnover for nurses and other providers throughout the state. Okay, and so here are some ways that we are going to be addressing some of the challenges with our new integrated plan. So there will be an increased focus on both education and campaigns to promote HIV testing and PrEP, as well as to address HIV stigma. We want to make sure we're increasing our collaborations between our mental health and substance use disorder providers. We want to continue to expand access to both PrEP and comprehensive harm reduction programs. We want to continue to work with our HIV surveillance, our local health districts, as well as our disease intervention specialists to improve our linkage to care rates for people diagnosed in the private sector and at local health departments. We want to continue to provide education on healthcare programs to optimize health outcomes, as well as to improve access to HIV treatment, testing, PrEP and other behavioral health services. We want to continue to reduce client and staff burden, as well as promote uninterrupted access to care and expand access through telehealth. Okay, so now we're going to go through the goals and objectives preview. As I've stated before, these goals and objectives are based on the 4 goals from the National HIV/AIDS Strategy. We are required to have at least 3 objectives for each goal. And I would like to note that these are just some examples. These are not inclusive of all of the objectives and strategies that we will have included in the plan. All right, just as a reminder, these are the 4 goals that our plan is based off of. Again, they look very similar to the previous goals or the previous plan's goals. All right, so now we're going to move into goal 1, which focuses on reducing new HIV infections. Here we want to, again, make sure we're conducting health communications to promote HIV testing and PrEP, as well as to address HIV stigma. We also want to expand our HIV testing in both clinical and non-clinical settings, as well as our home testing, pharmacy, and comprehensive harm reduction sites, continuing our no wrong door approach, as well as to increase the capacity of our HIV test sites to conduct both STI and hepatitis testing, as well as conventional testing. And then lastly, to improve access to safe and effective HIV prevention interventions, including increasing access to PrEP through new initiatives such as pharmacy-provided PrEP, teleprep, and adding PrEP to our local health department clinical services, expanding comprehensive harm reductions to ensure more equitable access across Virginia, and then expand condom distribution to ensure equitable access to those in need. Okay, moving into goal 2, which focuses on increasing access to care and improving health outcomes for people with HIV. First, we want to make sure that we are linking people to care immediately after diagnosis. And so with that, we want to continue our Rapid Start program, as well as expand protocols to both HIV prevention and care sites. We want to continue our status neutral service navigation program, as well as, again, continue to work with our HIV surveillance, local health departments, and disease intervention specialists to improve linkage to care rates. And then we also want to make sure we're increasing our re-engagement and retention in care and adherence to HIV treatment to achieve viral suppression. And so with that, we want to make sure we're educating our people with HIV on the most appropriate programs, whether that be Medicaid, Medicare, the ACA Marketplace, or Direct ADAP, again, the most appropriate program for which they qualify for, to maximize coverage and clinical outcomes, as well as to continue to ensure that Ryan White serves as the payer of last resort. We also want to make sure that we are continuing to expand access to support services such as housing, mental health, substance use disorder treatment, food, transportation, to increase retention and care, and again, achieve optimal health outcomes. Okay. Objective 2.3 specifically focuses on expanding services to older adults with HIV, as well as long-term survivors. Here we want to make sure that we are continuing to review our VDH medication formularies to make sure that they are meeting the needs of aging people with HIV. And we'd also like to initiate a partnership with the Department of Aging and Rehabilitative Services to support older people with HIV, including those in settings such as aging services, housing for older adults, substance use treatment, as well as disability and other medical services to make sure that we are assessing and addressing the needs of older people with HIV. Okay, moving on to goal 3, which focuses on reducing HIV-related disparities and health inequities. We want to make sure that we are reducing disparities in new HIV infections in both the knowledge of as well as along our HIV care continuum. So with that, we want to increase enrollment in PrEP services by Black and Hispanic MSM, Black women, transgender women and gender nonconforming individuals through stigma reduction. We want to increase the linkage, retention, and care and viral suppression among people with HIV who inject drugs through provider education and substance use disorder related stigma, the use of appropriate person-first language, as well as increased engagement with our comprehensive harm reduction and behavioral health providers. Expand equitable access to HIV treatment through the use of telehealth, mobile healthcare, and other mechanisms in rural areas, as well as for those with transportation challenges. We also want to promote a diverse HIV workforce that is representative of, as well as responsive to the needs of the populations that we serve. And so for that, we want to make sure that we are maintaining opportunities for both people with HIV and for those who experience risk for HIV, as well as provide or ensure that contracted aid organizations provide training to their staff on important topics such as racism, sexual orientation and gender identity, intimate partner violence, trauma-informed principles, medical mistrust, as well as person-first language. Okay, continuing. We also want to address social and structural determinants of health and co-occurring conditions. So with this, we want to continue the implementation of unified eligibility, as well as collaborate with our Ryan White counterparts and jurisdictions and other entities to reduce administrative burden for clients, to ensure access to quality HIV care and treatment, to assist people with HIV or those who experience risk for HIV with obtaining health insurance, as well as to improve data on our transgender and non-binary and gender non-conforming persons, to improve the data collection, reporting, and the use of our VDH, HIV, STI, and viral hepatitis data to inform services for the transgender and for the non-binary and gender non-conforming population. Great. Goal 4, which focuses on achieving a more coordinated response. So this looks at one, we want to coordinate with both our public and private partners, as well as our community-based organizations and academic partners to address the syndemic of HIV, STIs, viral hepatitis, substance use, and mental health disorders. So with that, we want to strengthen our partnerships with our community partners, such as our community services boards, HAPWA, other housing providers, as well as our Department of Behavioral Health and Developmental Services. We want to coordinate services among our community-based test sites and our clinical providers. We also want to increase the coordination of HIV programs across governmental agencies, as well as with our public and private healthcare payers, our community-based organizations, and academic partners. So with that, we want to work with our federal partners, including HRSA, SAMHSA, CDC, and HUD, to identify and reduce duplicative reporting, administrative burden, as well as barriers to seamless service delivery across the care continuum. We also want to identify and implement best practices for working across federal funding streams to ensure optimal outcomes for people with HIV and for those who experience risk for HIV. And then we'd also like to create a partnership with our other border states, including North Carolina, West Virginia, Kentucky, and Tennessee, to coordinate data exchanges and services across borders. Okay, and then lastly, we want to make sure that we enhance the quality, accessibility, the sharing, and uses of our data, including HIV prevention and care data, to measure, monitor, evaluate, and use this information to report progress and course correct as needed in order to achieve the goals of the integrated plan. And so some of those activities include continuing our DDP monthly outbreak rapid response meetings, to provide annual updates on the cluster detection and response program to our community stakeholders, including our consumer groups, as well as to build and continue on relationships with our state partners, such as the Department of Medication Assistance Services, Department of Behavioral Health and Developmental Services, the Veterans Administration, the Virginia Department of Corrections, as well as the Department of Social Services, to ensure optimal patient outcomes, as well as to identify areas of improvement and action needed across the HIV service delivery system. All right, and so then where is VDH in the planning process for this integrated plan? So we currently have a VDH leadership team that includes leadership from our HIV and hepatitis prevention unit, HIV care services, HIV surveillance, and STD prevention and surveillance. This team has been guiding the development of this integrated plan. We have currently finished the foundational work in drafting the plan. And so some of those steps have included collecting the information for the, the epidemiological snapshot, the resource inventory, and the community involvement and needs assessment sections. It's also included drafting our situational analysis, which again identifies our strengths and opportunities, as well as our gaps in service needs, as well as identifies priority populations. And then as we just previewed, we have also drafted our goals and objectives for the plan based on the information collected in the foundational work step. So we are now in the process of reviewing and finalizing our plan. And this does include finalizing our plan with our community partners, including the Community HIV Planning Group, as well as our Norfolk TGA. And then we will submit this plan to both HRSA and CDC. It is due on December 9th. Although we hope to submit on December 7th. All right. So again, that's a really quick overview of the entire integrated plan coming up for 2022 through 2026. Here is my contact information if you have any questions, and we will now move into the live Q&A.
Well, good morning, everyone. And Ashley, thank you for that presentation on the integrated plan. Can you not hear me? Okay. So we're moving into questions for the Q&A. Our first question is, can you talk more about how people living with HIV were included in the planning process? Did they get to help in developing the goals?
Sure. So part of the planning process for the integrated plan is working with our community HIV planning group. And this group is comprised of about 40% of people with HIV. They have been regularly involved in the planning process, including help develop the goals and objectives that are in the plan. And then we also held a public hearing back in April that was open to community stakeholders, people with HIV, providers, to get additional input into what was going into the plan.
Thank you for sharing. The next question is, if staff retention is a challenge, what is VDH doing to help agencies retain staff?
Sure. So this is something we are looking into. We are currently working on or we have put out a what's called a knowledge, attitudes, and belief a knowledge, attitudes, and beliefs survey on trauma-informed care, which is also looking at staff burnout at agencies. We are also we're looking to assess this more in upcoming needs assessments and public hearings to hear what challenges agencies are having with retaining staff, so that we can then look into how we can help our agencies retain their staff.
And I'll just add, we're creating a trauma-informed strategic plan, and the goals Ashley mentioned are in that plan as well. So we're hoping in the future that there'd be additional training coming up and some support. The next question is, as this is a second integrated jurisdictional plan for Virginia has done, what are some lessons learned from the first plan What feedback did we get from the funders, HRSA, CDC, subrecipients, and consumers?
Sure. I think one of the biggest lessons we learned with the first plan is to make sure that the activities and the goals that we are putting into the plan are realistic and achievable, and making sure also a big one that we can actually measure what we're putting in the plan. And so I think that was one of the biggest lessons. So one of the things we did is we actually went through all the previous goals and objectives and determined which ones we wanted to keep, which ones weren't working really. We also tried to be more less specific with our goals and objectives with this plan. In the previous plan, we had a lot of goals and activities and strategies that were so very specific that sometimes it was hard to either measure them, or sometimes if something small changed within the program, it changed then how we would monitor that goal. So some of the things you'll notice in the goals and objectives this time is they're a little more open, they're a little bit more broad. Some of the feedback that we received from HRSA and CDC for the first plan is that our monitoring and evaluation section needed to be a little bit more robust. So we actually have the HIV and hepatitis prevention program evaluator who is helping with developing the monitoring and evaluation section, so we can make sure that we're monitoring the plan and addressing any changes that need to be made. And I will say that HRSA stated that we had one of the strongest and most complete plans submitted by the Ryan White recipients.
Thank you for that. The next question is, will a draft of the plan be posted online for review?
Yes. We are currently finalizing that a draft this week that we will send out to our planning partners, including our community HIV planning group, the Norfolk TGA, as well as some internal leadership. And then I believe the plan is to post a draft of the plan once some of the internal planning folks have looked at the plan, then the plan reviewed the plan, then we will post it online for others to provide input.
The next is more of a comment, and I'll just read it. It's from Skype. I appreciate the usage of trauma-informed language, such as the Goal 2 objective 2.2. However, trauma-informed should be followed by anti-racist and intersectional lenses because it aims to acknowledge higher risk populations, persons of color, men that have sex with men. And I can let you answer if you want. I can add something to it too from our trauma-informed care plan. It does include anti-racism, intersectionality, as well as a continuum of care for HIV, HIV along the ACEs study, so adverse childhood effects, which includes like location. So it takes the whole person versus just looking at if they're considered a high risk population. And sorry, Ashley, I'll let you add anything else if you would like to.
Oh, no worries. No, I appreciate that comment. We really have tried to make this plan more trauma informed. And making sure that we are, using appropriate language. And I will say too, that what we provided in the presentation is just a highlight of the plan and a really, really short overview. So I guess I want to say that there will be things in the plan that weren't shown here, but that will be highlighted. A lot more work on trying to be more trauma informed, and more of that work is included in the plan.
The next comment is Ashley from Raymond wants to publicly thank you for integrating the graying of HIV points I made last year to include partnerships with DARS. Thank you.
Yes, that's definitely, thank you, Raymond. That's definitely one of the things we wanted to focus on with this plan, is making sure that we are addressing populations that are aging with HIV, and also populations that are aging who may experience risk for HIV. As we saw in the presentation, we're seeing on both sides that we need to do a little bit more with people who are aging. So wanting to make sure that we're addressing their needs across the entire HIV service delivery system.
Ashley, this is a follow-up question. What were the successes of the previous plan, and how did you build upon our strengths and successes?
Sure. So I think we had a lot of successes in the plan. A lot of the activities that we put into the plan, we were actually able to achieve. So some of those examples are implementing a rapid start program. That was something we didn't have 5 years ago when we initiated the plan, but it was one of those goals that we put in that we wanted to achieve. We were also able to, unify our eligibility for our Ryan White Part B. As you remember, we used to have our ADAP and the other Part B services were completely separate in terms of eligibility process. We were able to unify those, and that was actually a goal in the previous plan, as well as we've expanded on our trauma-informed approaches work that we've been doing both internally and with our agencies. And so what we've been, as I said, one of the things we did is we actually took each goal of the plan and we looked at, okay, did we achieve this? Did we make any progress on this goal? And then we either include it in the plan, and in many cases we expanded that, right? So we put a lot more details in terms of like what we wanted to see with our PrEP program and our comprehensive harm reduction programs, because with PrEP it existed, but it wasn't very robust. And with comprehensive harm reduction, that didn't even exist 5 years when we created the first plan. So you'll see a lot more concrete goals with some of the programs that we may not have seen with the first plan.
The next question is, can you talk more about the status neutral population and how to effectively address their needs?
Sure. I'm going to talk a little bit and then I'll probably ask Adiam to chime in since she oversaw the status neutral program here at VDH. But I think one of the things we've definitely seen is a need for services across the HIV service delivery system. What I mean by that, is that a lot of times we see a lot of support services that are available for people with HIV, but then there's not as many resources or funding available for people who experience risk for HIV and who maybe need those same services to help them remain HIV negative. So that is something we are trying to look into. That's part of why we want to partner and build more relationships with other entities that we know provide services to the populations that we serve. One of the things we put in the plan this year is trying to make sure that we are discussing, health insurance programs, right? So whether that's Medicaid or health insurance, and seeing, a lot of times we focus that for people with HIV, but that also is needed for those who experience risk for HIV, because that can help them get access to more services that they may need that maybe aren't able to be provided through some of our federal funding. And Adiam, I'll hand it over to you if there's anything you want to add.
I will just, because we're kind of short on time, I'll just overview it really quickly that it's a no wrong door approach. So with our status neutral grant, it's funded with food prevention and rebates. And so it's to provide, as Ashley said, the same services. So no one cares about risk for HIV if they don't have housing, if they don't have stability, job readiness. So the goal of the status neutral grant is for agencies to partner with other agencies that provide that supportive services so they can do a warm handoff for people and have those referral lists versus having someone chase around a bunch of different needs. We have 1 minute left, Ashley. And so we have a couple more questions, but due to timing, we'll try to follow up. I'll make sure Ashley gets those questions if we could follow up with folks. So we have 1 minute left, and that's all the time we have for questions. Thank you to our presenter, Ashley Yoakum, for sharing her presentation, Ending the HIV Epidemic and the Virginia Integrated Jurisdictional Plan. We'll go into our next session now, Consumer Reflections and Rapid Start. To access that session, please click the Join Now button. Thank you again for everyone that joined with us. We appreciate it, and we appreciate all the robust questions.